Let's start with group 3.
Group 3, you were looking at communitization of health services, especially this Rogi, ARS, somebody were asking, it's a Karnataka term for Rogi Kalyan Samiti. Yeah. We call it Arogya Raksha Samiti. Yes.
By communitization, it is assumed to enhance or improve functioning of health systems by implementing decentralized decision making, ensuring community participation, building sense of ownership and efficient resource allocation.
Okay. Is this a summary of what you said? So, you want to have community participation, increase ownership and efficient resource allocation. This leads to decentralized decision making, all these three, and that leads to improved functioning of the health system. These are the intentions of the implementers. For a moment, let us imagine that, of course, you have done it through discussion. Please sit down. You have done it through discussion. Ideally, how should this have been done? If you were evaluating Rogi Kalyan Samitis, what would you have done?
Evaluation of Rogi Kalyan.
What would have been? What would you have started with?
Interviewing the members
Correct.
of the
Who?
Rogi Kalyan Samiti and end users also.
Yeah. So this is a main mistake, I feel. Correct me if I am wrong. So evaluations start with beneficiaries or with people implementing. It's a wrong first step. It has to start with what was the intent behind this. So you have to go through the documents. You have to interview the people who designed that intervention, right? Because these things get lost. When we say JSY, if you look at the guidelines and the implementation, and if you evaluate it by looking at coverage of JSY, you are, I think, wrestling with the wrong animal, because everything that is intended does not often come out through guidelines. So you are actually evaluating the guidelines of JSY implementation and not the intentions and the reasoning. So we call this in the evaluation field, it's called the logic. This is actually a illustration of the program logic. Okay. So this is basically the set of ideas and assumptions that the designers had on why is this program expected to work. Okay. And what is very key for the why question in your logic? Can you point out? Anybody else from other groups? What is the key reason why, according to their logic, this intervention is likely to work? By key, I mean the limiting factor according to their logic. If that's not there, this one will not work. For me, I mean, it's still not there, but for me, something like ownership comes there. See, because remember, as an evaluator, you are not looking at the activities, you are looking at what drives people's choices. That is the underlying thing that a realist evaluator is getting at. He or she is not getting at where did it work, not the reason of where did it work, where did it not work, is to understand what is it that drove people to make choices towards decentralized decision making. So one reason could be, here in this case it is still a hypothesis, is that ownership, like in your case you said women's empowerment, is a very crucial pathway in this logic for driving community participation also. People will participate if, that's an assumption, that people will participate if they feel that they have some stake, they have some, not by stake I don't mean financial stake, but still some degree of identity or ownership over this facility. So the first step of evaluating any program or reform starts with unpacking this logic, and within the logic trying to ask what is it that is driving people to change their behavior. So I think the key here is that a program is expected to usually create a change. So the question for then evaluation there will be, why is it that this program started changing people's choices? Firstly, why will people change their choice in response to such a program? And if yes, did it happen in my setting? Did that logic play out? So thank you, group 3. So this is not yet what is called a program theory, but I want you to start appreciating the need to start an evaluation with this and not directly jump into evaluating users, community, the health workers, interviews with them. So this is going to be your frame. Okay, group 4.
Group 4.
Yeah.
Yeah, so we narrowed it down to incentivizing performance for ASHAs because we realized that for doctors, reasons were different and for ASHAs, reasons were different. So when we looked at ASHAs, ASHAs were envisaged as an activist, which is why it was never thought of proper payments for them. The actual salaries were not given to ASHAs because they were rather envisaged as activists.
Okay.
And then performance-based or differential payments were brought in for increasing motivation. So whatever they work for, they will. It's a motivation issue that if you pay more, if you work more, you'll get more pay. So if you give more output or if you bring in more results,
so produce more in some sense, outcomes,
yes.
or some bring a woman
right.
for antenatal checkup,
right.
etc.
Right.
Then if it's a plus, then money is more.
Money is
if
more.
it's a minus,
right.
this is at the outcome level,
right.
money is less. Okay.
Yes. So it was essentially the motivation factor that was addressed with the help of these.
So this was supposed to increase
motivation,
and so she will be more activist then.
Right.
Okay.
Right.
Is that how you looked at it?
Yes. That's how we looked
Okay.
at it. So
Anybody else from the group? This is somewhat the discussion, na? So what do you think, the others? I think it's let's not get into whether this was the actual logic of ASHA. That's another debate. So what you have gone at is actually the basic underlying assumption behind performance-based financing, that people are working less. If you give them incentives of some kind, it improves their motivation to perform more. So more money, more performance. Less money, less performance, and then the less money people will see, hey, they are getting more money. If I also perform, then I will also get more money, right? So as an evaluator, if you are evaluating performance-based financing, what is it you should evaluate? Not who got more money, how much money was distributed, interview with them, etc. You are evaluating this idea actually. That is what I am trying to say about program theory. Program theory is not actually this logic. It's about why is there this logic? What is the theory behind this logic? In this case, in the case of group 3, we couldn't arrive there for various reasons because of the amount of information we have, etc. Ideally, this kind of thinking precedes the evaluation. So we start the evaluation saying, why should this program work? In the case of performance-based financing, it ought to work because people are maximizing their self-interest. And you are now going to check in your setting, did people try that? So your interview tools will also be designed keeping that bias in mind. So we are basically like the economist was talking about, like Shankar was talking about assumptions. Here we are also saying there are so many assumptions. Let's try to get them on the table, organize them, and wear them as our lens, and go around looking. Because otherwise you will get lost, right? Otherwise you can evaluate various components of performance-based financing. Okay, it doesn't work. You can say we looked at A, B, and C setting. It doesn't work. C, D, and E setting, it doesn't work. But when you go with this logic, you are trying to get at what is the reason it doesn't work. Maybe you will find that everybody is not buying into that sort of self-interest argument. So maybe you will find that people say, look, I became an ASHA because I wanted to be recognized in the village, not so much for the money. Somebody else may say, in our family, my father wanted me to be a doctor, but I couldn't fulfill that aspiration. So I thought I'll be a health worker. So there are various perceptions and things behind. So when you do this exercise before, it gives you that sort of a framework, a lens, a worldview into that program, right? Let's go to another group. We'll summarize at the end on a bit more on program theory and things like that. Group 1, let's see. Somehow I think group 4 infringed onto your territory. Okay.
We could not arrive on any theory, but we were looking into the fact that which components were added when whoever has thought of involving community health workers as a new cadre. So we came into all those components, like we thought of, okay, they have included bottom-up theories to start with, and they added community members, especially women, to link up health sector with community.
Okay.
They improve community participation by involving women.
This improves community participation. Okay.
They minimize barriers for the women, specifically for the women group in the community, and improve their access to health utilization.
Okay. So these women have certain, there are several long jumps and high jumps to the health service. So this ASHA will remove those barriers and then they can now reach the health service. Okay. And they will increase community participation somehow. Yeah, is that all?
We have also come into the point that this ASHA strategy is like many other factors are also including, like this is a evolving kind of program which is not static, like few decisions are making, policies are changing, and many activities are included in ASHA's work.
True, true. That's of course true with many others as well, but more so in the ASHA case perhaps. Okay. There were some success stories in small places where this sort of thing seemed to have occurred, and now that fed into, so this was the sort of logic behind the ASHA model. It worked there, so we will make it work across the country. But you see again, say very interesting assumptions which actually result in the variation we see. Things, for example, that she will remove, that there are these barriers and that she has what it takes to remove those barriers, right? So that she has the capability, the confidence, not only the knowledge and skills, but she has the capability and the confidence to be able to help people negotiate through these what we call barriers. That it will increase community participation, right? Again an assumption which needs really unpacking. So this whole exercise of program theory development idea is not to just do what you guys did in a short discussion, but is to, before touching evaluation or before talking about a program or a policy, getting into the underlying mechanisms, we say. What are the underlying mechanisms which make a program or a policy work? And the underlying mechanisms are not at the level of, oh, it will lead to community participation. No, we'll have a woman that will remove barriers. These are just observations that you might find. You may find that in village A, community participation increased and village B did not, right? These are observations. What would you call an underlying mechanism in this case? For example, underlying mechanism would be 21 days of very pedagogically sound activist training triggers an activist within an ASHA. That is a mechanism. So then you as an evaluator, right, because if that were to be true, then she is able to then negotiate. We actually, this is a way of addressing complexity. When you have a mechanism at this level, do you see that? Maybe let me unpack that. Suppose I frame my hypothesis as that 21-day pedagogically sound ASHA training programs triggers an activist within rural women, right? So the program could work, ASHA program could work if the selection was specifically tilted towards picking up people with an activist mindset. 2, it could work if the 21-day training program, I don't know which 21 days, I keep saying, is it 21 days or 21 days? Okay. If the 21-day training program triggers an activist or triggers a feeling of wanting to improve community service interface within her, right? So this, why I am saying it's a way for you to tackle complexity is because now you have put it into a human being, because human beings, as we saw in Joe's and Kabir's lectures, behave differently in different circumstances, conditions, societies, cultures, political scenarios, right? So here we are not making a statement of who will behave how, but we are saying if that gets triggered in any person, she will be able to negotiate any barriers, be it a very difficult PRI, be it a remote area. If she would trigger that mechanism, she is able to do that. So that's what the idea of your intervention logic is building is at. Okay, we have still not gone into the evaluation, remember. So this exercise for the realist evaluation, actually many evaluators do this. Let me not say realist evaluation is the one discipline which is doing this. When I keep saying realist evaluation, don't think this is something special that we are doing it. Many evaluators do it, but in this field there is a certain rigor given mentioned to this. Many qualitative researchers do this. In fact, they build a framework before, but we give a lot of thought for a program or policy to build an intervention logic. This is based on two things. One is your interviews with the implementation designers, not the implementers. Yeah, the documents, guidelines, etc., that you can lay your hands on. Exactly, but also scanning literature, because community health workers is not something that we discovered. It's been talked about, right? So you have to scan literature for why is it that people said it has worked elsewhere. It need not be all peer-reviewed literature. It can be anything. It can be stories. It can be an ethnographic work. So you build your framework, intervention logic, based on an understanding of wider literature as well as a detailed interview with the implementers. And when you are interviewing the implementers, remember, and this is very easy to think, yeah, I know this, which is not going deeper than the activities and asking why. For example, why is it that she is likely to increase community participation? What is it? And when you are asking why, it's not about technical program elements. Again, it's about people. Why will people make a choice? Why will people behave differently just because an ASHA program has come? So why is it that when people are invited to Rogi Kalyan Samiti, they will start becoming owners of this place? Why will they positively engage with the service? Why will they not disrupt things, right? Which happened in many Rogi Kalyan Samitis. There is a lot of disruption. Why? So these kind of questions help you to unpack your logic beforehand, and the more you unpack beforehand, the richer is your evaluation, because remember that there is no way you will get all the answers. So you will get answers to what you are looking for. This is the realist mindset. It's slightly different from how ethnographers would look at it, I think, from my understanding. Let's go to group number 2.
So our group will try to look at the intentions behind the training programs that are instituted, the management-oriented programs instituted for district and block level health workers. So we feel that traditionally most of the block level and district level health managers come from a clinical background, and the roles that their duties that they are expected to perform are more managerial as well. Okay. And so to address a possible training gap is why the programs are there. And also it would address, I think, some of the barriers or for non-implementation of programs that we've discussed over the last 1 week, which is that they don't have enough sufficient capacity.
So what is the training program giving the person?
It's giving them skills to run a program. Yes.
And that leads to better program implementation.
And also increases the technical efficiency of the manager, because there's a conflict between the performance goals that he has for vertical programs versus performance goals he has within his role as a...
So he will be better able to allocate time and resources to vertical programs and to health services, general health services. Okay? Yeah, is that other group members, is that a fair representation of your logic? Okay, any thoughts? I see a lot. Do you see a lot of difficulties in these arrows? Tell me, just for a moment be critical of this. You are saying they are clinicians and they don't know management because they are clinicians, right? They are in management positions. Yeah, they have not been trained as managers. Okay. And now we are going to equip them with skills, right? Skills to the clinician, management skills to the clinician will improve program implementation, because now he knows a log frame, he knows how to review meetings, etc. And then it will improve efficiency. He is now able to manage programs versus health services. Think critically. What's missing? Okay, but what's missing from what ground we have covered till now? Read the second one. What is the assumption you are making here? That the clinician posted as a manager is just waiting to grab skills. He's just waiting, and that's one injection of skills we give. he is now going to change the world, right? Isn't it a somewhat an oversimplified summary of your logic? Okay, he will change the district. So what is lacking here? Yeah? Yes, the motivation. Okay, shall we add that? Shall we say, okay, the clinician to manager, but if he has the motivation, then he will do this. Is that okay? Okay, then what else is lacking?
Personal interest of
Okay, motivation. If the technical efficiency of service and the programs have to be better implemented, what is it? Only skills? There are a lot of things he should be able to negotiate, no? The institutional environment, the policy environment, the ability to lead people and make people change their choices. So he needs to be able to do all that. So now here, if this logic as an evaluator, you are going to start asking those questions. That's what the logic building is about. You are going to ask, what is it about this training that made people more motivated, or what is it about the training that changed the conditions prevalent in that district for the manager to be able to implement things better, right? And if it did not, if those things were not done, and if it was an industrial scale training program like we have all the time, then nothing much will change. So that's then something that you will find out. Okay, but let's summarize this exercise. So the exercise was about trying to look at the realist worldview. We have not started the unpacking the evaluation method itself. We have seen till now that in this lens, we look at the second bullet point. I would like you to pay interest. Programs work through people and their choices. Remember, we are too mechanistically trained to imagine that programs work because of amazing objectives, or the activities, the log frame has been so nicely designed, so much detail in the log frame. We are so mechanistically trained sometimes to imagine that programs work through good design. Design matters. It's not that design does not matter. Your design has to be adapted to the condition where you are implementing, but programs have to alter people's choices. They have to make a new way of doing things, the change that we were talking about. How is your program going to make people find a new way of doing things in that organization, right? So that's something to keep in mind. So actually many countries, many of the high income countries today make it compulsory for government resources, wherever government resources are spent, for program theories to be made explicit. It's not a practice, certainly not here, but in many high income settings they say that the people who design an intervention have to spend time in articulating before and a priori why is it they expect this intervention to work. So in some settings they do it as an accountability transparency measure as well, because guidelines and documents don't really tell you why is it we started this program, or rather they root it in some sort of evidence, literature tells us, or some survey told us this, etc., etc. So given that we don't have that, we as an evaluator need to go and unpack it, and you have to wear all the lenses that we were exposed to earlier. You can wear your policy lens, your political economy lens, etc., and bring out the possible theories underlying these programs. Okay, let's go a bit into the realist process itself. So actually when we say realist evaluation, it's just a new, it's somewhat sort of a trending evaluation method within HPSR, but it is rooted within a larger field of evaluation which has been there for a very long time, called theory driven inquiry, right? So where your inquiry into a policy or program is driven by a theory on why it should or should not work. So there is also this interest in mechanisms. That's the second thing. Why is it this program works, rather than only how did it work or not. And what are examples for mechanisms? Mechanism is again things within people. Why is it that you would choose to, like in your case you said zero prescription policy, right? So you have a policy where doctors are forbidden from writing prescription to a private pharmacy. In Maharashtra it seems they have implemented it recently. As an evaluator, I am saying why will this program work? What is the most crucial aspect of this program that has to happen, otherwise it won't work, without any value judgment on the doctor. So, and assuming that he needs the right structure and the agency to be in place to change his behavior. Yeah. So, why is it that this program of zero prescription policy should be working? I was earlier saying that it has to work only if it changes the prescription behavior of the doctor, right? If it does not create the conditions needed for that doctor to change his behavior, or for example, he says, look, come to my clinic later in the evening, here I can't give a prescription, come later in the evening to my clinic, for example, that could happen, right, for some reason, and that could be a coping mechanism actually. Because of your policy, now he is driving people to his clinic, right. So, if that does not happen, if he does not buy into your program logic, this program will not work. That is what I am saying, and that I am calling that as a mechanism. And from what I understand, Matthew is pointing out that it is not only about his individual choice. It is not that it will work only if I make a choice. It is a lot of other processes. What leads to that choice? What conditions exist for me to make that choice? And that is really what we are talking about. We are saying from an initial situation to a change situation, while there needs to be a mechanism, it has to happen within a certain context. So, the idea of this intervention logic is to then discover the interplay, the dynamic interplay between the mechanism and this context within which the action is implemented. So, as an evaluator, you are not only bothered about the mechanism, let me not give you that impression. It is not that you are now going to say, oh, who changed behavior, who did not change behavior. It is not only that, I will come, but you are trying to understand what is the interrelationship between the kind of conditions that cause behavior change, or what kind of behavioral change happens under what kind of conditions. That is another way of framing it, right. So, there is the individual doctor, okay. And now we are saying that the mechanism of this program is targeting prescription behavior, while completely acknowledging that prescription behavior is not an individual outcome. It is not just my choice. So, individual doctor from status A reaches status B, right. So, today he is giving outside prescription. So, from this status he reaches to a state where he is not giving outside prescription, right. We start from here. And we say first, we interview the people, they say, look, I am going to make assumptions here, I do not know about this policy at all. So, maybe the policy maker says, now we have increased allocation, we have given a new scheme, so people can have higher untied fund, they can buy their drugs, okay. So, resources and availability is going to improve, right. So, that is one assumption, because their drugs are available, he is going to prescribe from within his facility. But then we know from our experience that prescription in the facility is not entirely based on availability, right. It is also based on doctors' perception on quality, for example. Doctors perceive that generic drugs do not really work, they need. Second, it could be about combination drugs. You know, the single dose thing the government is applying according to essential drugs list, and essential drugs list does not have combination drugs. I need that. So, there may be technical reasons for him to not make this choice, right. There may be now the institution where he works. By institution I am not talking about the PHC, but the health department, the environment, the context of the health department. Here there may be, for example, you can put in mechanisms like peer pressure. So, maybe when you interview doctors in your program theory building, you find that doctors tend to influence each other's behavior, right. So, that could be another mechanism, it need not be only here. So, we discover a new one. We say peer pressure and social networks among doctors could play a great role in influencing this policy. Then we say, but then wait a minute, it is not every single PHC doctor who will just succumb to peer pressure. What about doctors in very adverse conditions, in remote areas, where or doctors who have a difficulty with the Panchayat Raj institution, PRI. There is some ongoing fight, or there is a very corrupt panchayat member, or he is himself very making informal payments, so he is not very, so then there is other individual level mechanisms, his own motivation as well as relationship with PRI. And then there is a wider circle. What about doctors who have a private practice in the evening? Are they likely to now push patients out into their practice because in your hospital there is zero prescription? Is it now going to lead to patients moving from public to private sector? Okay, but to wrap up quickly, so what I just now did is patient perspective also drives it. So did the zero prescription policy work with patient groups? For example, did it build pressure from the community? What he was saying, the community perspective. So what if in some places, let's say the MP, so as a realist evaluator, what I would do then is I will test it in the home constituency of the MP who was pushing for zero prescription policy. I am making assumptions that one MP pushed it, but I am saying. So there we assume that another condition should have been met. This MP would have told his guys, hey, I have launched the scheme, tell everybody they are now going to get medicine. So did that drive this doctor to make switches, or did it contribute? It cannot be all one. So what I am doing now is rapidly making assumptions, but still somewhat rooted in possibilities that are guided by some theories. So I have some theories here. I am saying peer pressure is a theory actually. The fact that people change behavior because they belong to a certain peer group is actually a well formulated theory in organizational psychology. The point is I made a bunch of these assumptions, went from micro to macro level, and this exercise now gives me a lens. Yeah. So then I will start looking at all of this. I will say which are all of the scenarios that played out in my reality. So let's not get too fixated on is something realist evaluation or not. In the realist worldview, this is how programs work. That's what I'm trying to say. If you would now like to just use qualitative research while embracing that you want to look for diversity and explain the diversity, somebody could call this, oh, this seems like a realist approach, whether you use the word or not. The key point is that I am trying to look at what makes people change behaviors, in what kind of conditions. The conditions are very important, not just the behavioral change. What kind of conditions drive what kind of behavioral choices? That's it. That's what would make it a realist evaluation, so to use the term. So you can evaluate zero prescription policy using any approach. In the realist evaluation approach, you start with the question as to which kind of doctors change their behavior and why, who did not and why not. And before starting, you are starting with some sort of a theoretical understanding of what drives behavioral change. Okay.